Welcome to Day 3 of the 2021 PQA Annual Meeting. I am Lauren Kirk, PQA's Senior Director of Strategic Partnerships, reporting to you live here from the PQA News Desk. So far, we've covered quite a few topics, including value-based care, social determinants of health, COVID-19, equity and medication use quality, and patient engagement. And we want to know what you think. So fill out the meeting evaluation form, which has been made available through the meeting application and the notifications there, as well as your emails about the meeting. As you may have experienced, we encountered some technical challenges with the streaming of the PQA Awards presentation, and we want to recognize the accomplishments of these remarkable students, providers, and organizations. So I encourage you to view the on-demand recording of those presentations and explore the incredible innovations that are improving medication use quality. We have another packed day ahead, 2 more general sessions, 7 more focus sessions, and plenty of time for you to collaborate with your fellow attendees and the meeting sponsors. So please continue to navigate the tabs of the online meeting platform to attend sessions and connect. Once again, we thank our sponsors and supporters that help make the PQA Annual Meeting possible. You have heard about these organizations throughout the meeting. Now, go connect with them. Learn more about some of our sponsors through the on-demand recordings of the Innovation Theaters, as well as the Walgreens program briefing yesterday morning. For now, let's hear a message from the sponsor of this morning's general session, Involve Pharmacy Solutions.
Involve Pharmacy Solutions provides total drug management that includes pharmacy benefit and integrated specialty pharmacy solutions. When it comes to pharmacy benefits, one size does not fit all. We customize our solutions to fit our clients' unique needs. As a top PBM, we have the clinical expertise to provide tailored programs that reduce costs while improving care. Contact us to learn about our innovative PBM services.
Thank you to our friends at Involve Pharmacy Solutions for your support. In April of 2020, and in the midst of the pandemic, PQA began tracking the issues affecting quality measure performance, new measurement needs, and the opportunities for expanding pharmacist-provided care. Like all of you, we adapted. PQA listened and leveraged our convening power to understand COVID-19's impact on the performance measure programs. PQA's Lisa Hines joined us now on Day 3 of the 2021 PQA Annual Meeting to host a panel reporting out on what we know of the COVID-19 impact on quality. Lisa?
Good morning, everyone, and welcome to the second general session of the 2021 PQA Annual Meeting. We're going to discuss the impact of COVID on quality, and this topic is of strong interest for our members. My name is Lisa Hines, and I serve as PQA's Chief Quality and Innovation Officer, and it's my pleasure to moderate this session. In response to the COVID-19 public health emergency, the Centers for Medicare and Medicaid issued temporary regulatory waivers and new rules to provide Medicare Advantage and Part D plans the flexibility they needed to focus on caring for beneficiaries affected by the pandemic. CMS also released interim final rules that address the impact of COVID-19 on the Part C and Part D star rating. During this session, you will hear an exceptional overview of policy changes to the 2022 and 2023 star ratings in response to COVID-19 and learn about insightful trends in medication utilization observed during the first year of the pandemic. Our 3 expert panelists will discuss the impact of the pandemic, expected and unexpected, and the continuing challenges, opportunities, and unknowns. In presentation order, our first panelist is Rex Wallace. founder and principal of Rex Wallace Consulting, a star ratings consulting firm. Rex's previous 25 years of healthcare experience had a strong focus in Medicare Advantage. Next is David Dodge, the Medicare Stars Program Director at Cambia Health Solutions. David is trained in economics and previously served at Cambia Health Solutions as an actuary. Our third panelist is Chris Powers, Vice President of Medicare Part D Stars at Cigna. Chris was previously at CMS, including during the launch of the Part D program and star ratings. Welcome to Rex, David, and Chris. Thank you so much for joining us today. I'll first hand it over to Rex.
So before we get into policy, which is what I'm going to recap here initially, I do want to ground us on just probably three key dates. If we go back to the beginning of the pandemic, early last year, which feels like a lifetime ago, but around January 24th, the first COVID case hit the US. And then on March 13th, the president declared a national state of emergency. And by the end of March, all 50 states had declared a state of emergency. Those are important as we talk about the disaster relief efforts as they relate to quality improvement in Medicare specifically. And just to orient you on this slide, the left side is regarding the 2022 star ratings. And when we think about 2022 stars, it relates back to 2020 performance. So think of care delivered in 2020. So office visits, medications filled and refilled, things like that. Also is the 2020 data collection as it relates back to those office visits in 2020. We conduct the HEDIS medical record chart collection in 2021. We also conduct a CAPS survey, a patient experience survey in 2021 that looks back on 2020. So both of those elements, the 2020 performance or care delivered in the year and the 2021 data collection as it relates back to that 2020 care, they both impact 2022 stars. So the left side relates to that, and the right side fast forward 1 year to performance this year in 2021 and data collection next year in 2022 and how it relates to 2023 stars. One last thing before I get into the policy details is what you won't see on here is changes made necessarily to 2021 stars, which there were some changes in 2020 regarding the CAP survey. CMS didn't count it. They didn't require that plans finish the CAP survey in 2020. They also didn't require that plans collect medical records as part of that HEDIS data collection effort in 2020 as it related to 2019 care. So because it's not impactful to 2022 stars and 2023 stars, that's not included on here, but that definitely happened. As we look to policies that impacted 2022 stars, one of the first things CMS did when we were all concerned about, the impact of the pandemic on access to care, on deferred care in 2020, is they provided some additional flexibility to plans. So they allowed plans to remove refill too soon edits, to expand telehealth provisions beyond what was in the filed bid benefits for that year. They allowed plans to remove restrictions that discouraged home delivery of drugs, things like that allowed members to access care a little more easily. And that was really important, obviously. And the next thing we get into is the disaster relief, which is so important. It's the extreme and uncontrollable circumstances policy. And I'm actually going to invite one of our other presenters, David Dodge, to kind of go over this section, because he and his team were instrumental in raising the flag early and understanding this policy and saying, our current policy doesn't really, it's not going to fit with the damage that's coming from the pandemic to quality scores. So, but David, I'll turn it over to you. Can you enlighten us on the EUC policy?
Certainly, I'll try my best. And so, with the extreme and uncontrollable circumstances policy, this is for disaster relief. Most of the time, this is tied to natural disasters, right? We see this tied to hurricanes, wildfires, tornadoes, things like that. Typically, in this case, because of the COVID effect that started affecting 3 different states in March of 2020, pretty quickly, by the end of the spring, we saw a situation where the majority of states and territories all had disaster declarations on a statewide basis, so much more broadly than would otherwise be the case. And so that put CMS in a challenging position because under the 60% rule of extreme and uncontrollable circumstances, they can't use data for those plans with at least 60% of enrollment in areas that have had a disaster. And that's because they don't want that data to bias cut point calculations. But we reached a spot last summer where we would have had the preponderance of plans be excluded from calculating cut points. And so one of the first things CMS did, and they finalized this in a August or September 2020 final rule, is they relieved the pressure. So they relaxed this 60% rule. And then that's what allows the second bullet under EUC here to apply. That's what allowed the higher of provision to apply. And so what contracts are going to see in the 2022 star ratings, and I think we're all pretty familiar with this, is that higher of 2022 or prior year star ratings, which is very beneficial, and certainly appreciate that prompt response from CMS, giving plans a sense of what's going to happen here, really even before 2020 ended. The item that you can also see on here is that the improvement measure hold harmless was expanded. A couple of anomalies to pay attention to for plans. One is if you have data integrity issues in the 2022 stars, and this can often happen with contracts that have, say, fewer than 7,000 members in them. Lots of contracts do, right? You could be in a situation where higher of last year's star ratings and this year data integrity issues, maybe you didn't have enough data to reach a credible standard. The higher of in that case would be this year's data integrity issue. And so you wouldn't receive a star rating for that measure. It's definitely something that can happen with smaller contracts with credibility standards for certain measures. And then the last thing I'd call out is, those measures that are excluded from higher of, these are the call center measures. And so the call center campaigns that are happening right now, those are going to, they'll be the only measures that will be used. There won't be a higher of provision applied to those two measures. And with that, Rex, I'll kind of turn it back to you after having touched here on the EUC.
Thanks, David. That was very helpful. So, and I'll invite you back when we get to 2023 because there are some important elements there as well. One more thing on the 2022 stars is the you'll see cut point guardrails delayed. So, in for 2020 performance, CMS had planned on implementing some guardrails, and the reason is because one of the things that plans complain about or have a hard time with regarding the current star ratings program is the fluctuation of cut points and the inability to predict where you're going to land and where you're going to land on scores and revenue in the future, et cetera. So to alleviate some of that, CMS had agreed to implement guardrails to not allow cut points to move more, for most measures, to move more than 5% up or down. So to keep them fairly tight so plans could predict where they're going to land a little better than they can now because cut points can fluctuate dramatically now based on industry performance. But because of the pandemic and the anticipated decline in performance that a lot of plans might have, obviously, as a result of this deferred care and barriers to access, et cetera, CMS said, okay, we're gonna delay the guardrails for 1 year. We won't put them in this year. We'll allow cut points to decline if they need to, so that plans aren't penalized, so that cut points can accurately reflect performance. That's a good thing for plans. And then controlling blood pressure is a measure, obviously in the HEDIS space, a Part C HEDIS measure. It had been taken off of star ratings for a couple of years because NCQA was making some specification changes to it. It was put on a display page, and then it was scheduled to come back onto the main star ratings program for 2022 stars. But because of all the challenges around data collection and access, CMS said, we're going to delay the bringing back of controlling blood pressure by 1 year. So it's not back for 2022 stars after all. And then lastly, the health outcomes survey for 2020 was delayed. This, however, was just delayed a few months. Typically, it takes place between April and July every year, which is right around the same time that the CAP survey takes place, which is typically March to early June. CMS did launch the health outcome survey just later in the year. So instead of April to July of 2020, it launched August through November. And CMS and NCQA, I guess, like that timing because they're saying that's going to be the permanent time going forward. So going forward, that will be a permanent change. CAP survey will be in the spring. Health outcome survey will be in the fall. If we fast forward now 1 year, some important changes for this performance year as well around 2021. And, one of the most important things is we don't expect any EUC relief this year. And David, do you have insights or comments you want to bring to us here regarding 2023 stars?
I mean, Rex, I've read the same thing that you have, right? The only EUC that would apply for 2023 stars would come out through further rulemaking. And that, of course, is barring, any disasters that occur, of course, heaven forbid, in the remainder of this year. The one thing I'd encourage all plans to do is, closely track this 2021 data. Is there some way in which your experience is somewhat different from what's happening around the states? And then, seek the counsel of other plans, seek the counsel of CMS tied to measure level declines. Because I think it's going to be a challenging year, and I think we're all going to have this sort of return back to the pandemic back from the pandemic that occurs at different rates. The one set of measures that I'm sort of closely paying attention to because I'd like a little bit more clarity on is the HOS survey. I'm trying to better understand how the HOS survey may be affected, may receive some sort of EUC treatment in 2023 stars. We haven't heard from CMS on that quite yet. Admittedly, 2023 star ratings are a ways away from being shared with us, but those are a couple of the things that I'm looking for. What are other plans experiencing, and is there any outreach to CMS to guide further rulemaking processes? And then also, how exactly is HOS going to be calculated in 23 stars?
Thanks, David. Next, controlling blood pressure. We talked about it last, on the left side, right, where it was supposed to come back for 2022 stars, and it was decided to be delayed and brought back in the next year. So it is expected to come back for 2023 stars, and it has some timely changes. The reason it was taken off in the first place was because NCQA, made some specification changes, and one of those being allowing members on a virtual visit, a telehealth visit, or even a telephone encounter, if they have a digital device that records their blood pressure, to be able to use that to close the gap on the phone, right, or on the telehealth visit, to use that digital device. So this is a really timely change, especially with this pandemic and the expansion of telehealth, obviously the adoption of telehealth. That is a key change. So a lot of plans are focused, obviously, on controlling blood pressure this year because it's back in 2021 performance. So as we speak right now, there were some other HEDIS measures, some new HEDIS measures that were expected to come on to the STARS program for 2023. Transitions of care, and then a follow-up after emergency department visit for members with chronic care. These two measures were supposed to come back on, or supposed to be new on 2023 stars, but CMS, because of all the delays regarding the pandemic, they did decide we're going to wait until 2024 stars. So those two measures will come on to stars in 2022 performance, which will be for 2024 stars. So those are huge topics of conversation within Medicare health plans right now. To stand up interventions and to make sure they're ready for those in January when those measures go live. Plan all-cause readmissions, like controlling blood pressure, was taken off for a couple years, was supposed to come back onto the STARS program for 2023 stars. It's being delayed one more year. It's expected to come on for 2024 stars. There's a new cut point methodology. It's called the two-key outlier deletion methodology, and it removes outliers from the cut point projections or calculations. And in simulated analysis, it's going to have a pretty big impact on the lower star ratings measures, and this will actually cause around 15% of plans to drop half a star, right, in the simulations that have been done. This is a big deal. It's going to hurt plans. However, it was supposed to come on and be implemented for 2023 stars. It is being delayed 1 year and expected to come on for 2024 stars now. But that is something to be aware of and to watch for. Member experience. So the patient, access and complaints and grievance measures. These are historically were a weight of 1.5. They've been increased to a weight of 2 for the last couple of years. For 2023 stars, they are rising to a weight of 4. So they will be the some of the most important measures obviously out there. There are 16 of them, and they will make up more than half of the weight of star ratings all by themselves, starting with 2023 stars, which is compelling in and of itself. Even more so when you think about the impact this could have on, related to the pandemic, and I think you'll see this play out with health plans benefiting big time in these weight increases if they were effective at reaching out to members during the pandemic and holding members' hands, during this these access challenges, and making sure they had medications on hand, really aggressive about holding members' hands throughout this process. I think you'll see those plans benefit greatly from these increased weights. And then the last thing I'll touch on is the guardrails that were supposed to be implemented for 2022 stars that got delayed because of CMS wanting the guardrails, or wanting the cut points to be able to drop appropriately to mirror industry performance. Those guardrails are going into place for 2023 stars. And we don't know exactly what performance is going to look like and how those guardrails, where they will lock in at, because we don't have a lot of data yet. The public data really comes out in September, right? So we'll get our first big visibility around sort of all data in September and how the cut points will be impacted. But we do have some data. And actually, Chris, one of our presenters, has some great pharmacy data that we're going to dig into next. So Chris, I will turn it over to you.
Thanks, Rex. So I'm going to talk about a few charts from the Evernorth 2020 Drug Trend Report. For those of you not familiar with this report, it was formerly known as the Express Scripts Drug Trend Report. Evernorth is a new subsidiary of Cigna that essentially combines several of the health services company under one umbrella. Data from this report are based on the overall book of business, which is predominantly based on commercial lives. This first chart describes the change in new medication users and utilization among users between 2019 and 2020. As you can see from the blue bars on the right, the number of new users declined across the board in 2020 in these key drug classes. Now, this may not be surprising, knowing that many people had avoided seeking care during the early phase of the pandemic. However, it is somewhat concerning to see decreases of around 7% for asthma and COPD and nearly 3% for cancer. On the other side of the chart, the green bars represent utilization among users, which increased for all of these drug therapies. Now, this may seem a bit surprising, but really when you stop and think about it, we know that health plans, pharmacies, pharmacists really went above and beyond to make sure their customers had access to medications during the pandemic. This next chart shows the change in medication adherence rates for the 3 drug classes used by CMS in the Medicare Stars ratings program. As you can see, adherence rates increased at a much higher rate in 2020 compared to 2019. In a typical year, we may see increases of 1 or 2% across the industry, but in 2020, this data shows that we experienced increases of upwards of 5% for diabetes and around 3% for cholesterol and blood pressure. So it's very clear that industry was focused on ensuring access to these important drug classes despite challenges caused by the pandemic. Hopefully this data helps set the stage for our discussions today. Please, I'll turn it back to you.
Thank you so much. I really appreciate the overview of the policy and the data trends, and you guys already provided some insights. I'm sure there's more that you want to highlight or discuss, or you might even have some questions for each other, and I might even throw in a question or two. So, Chris, I was going to hand it to you to see if you had any questions for our other panelists or any comments you wanted to share.
Yeah, thanks, Lisa. Rex, really appreciated the overview of policy. One of the questions I know that we've received a lot was around caps and whether caps will be subject to the extreme and uncontrollable circumstance policy. Any thoughts there?
Yeah, Chris. Yeah, no, good question. This came up a lot in the interim final rule with comments. In sort of a series of them, it was addressed, but it was ambiguous, right? The language was a little confusing because of the difference between the 60% rule and the 25% rule and how caps fits into each of those. It made it sound like caps didn't necessarily apply to the higher of provision, but it does. It does. So I know we've gotten confirmation from CMS, since then that yes, caps measures will be included in the higher of. So you will be able to, you will be assigned a higher of, the 2021 survey or the 2019 survey actually, because the 2020 survey didn't count. So to answer your question, yes, it's definitely our understanding that caps will count in the higher of.
Great. And then I think the other question that we get a lot is around new contracts. It doesn't seem that there's clear policy for something to fall back on for a new contract because there's no existing prior year data. Do we know what the thinking is for new contracts yet?
So, so far what we know and what we understand, and David, I'll invite you to jump in too, is that there will be at a slight disadvantage because they like you're saying do not have a prior year to fall back on, so they will only receive their performance during the 2020 measurement year, the year of the pandemic. So they might very well suffer slightly from that. We don't know for sure what those scores will look like, but to answer your question, yes, they will be at a slight disadvantage because there will be no second alternative score to pull from a prior year. And Chris, I actually have a question for you, if I can jump in. But the medication adherence rates climbed in 2020. Partly I think, and I think you addressed this right, because of the restrictions that were lifted and the things that plans were able to do to make sure members had a supply of drugs. We also saw this happen, or we don't have final scores yet for the industry, but we're seeing this play out in many HEDIS measures, and then in the CAP survey is still underway, and we're seeing it so far play out in the CAP survey too, where scores are actually not declining always. They're many of them are climbing, and I think a lot of this is because of those restrictions that CMS allowed plans to remove. My question is, when those are put back in place, do you anticipate on the adherence scores, are we going to see them drop because now they're those previous, maybe not barriers, but less restrictions or more restrictions and less relaxations, will not make it quite so easy for members to access medication like they are now. But do you have thoughts on that?
Yeah, it's definitely something we're concerned about. I think on the medication front, mathematically, somebody can accumulate medication during the year. If restrictions are removed, that'll carry them into the next year. And the way adherence rates are calculated, it's within the calendar year, not really accounting for those medications that carry forward. So a person may administratively look very non-adherent in a year when in fact they're taking their medicine every day because they have enough on hand. And so there's a little bit of concern about mathematically what that turns out to be. But then there's the reality too that people may go to the pharmacy, experienced the ability to get the medication a little earlier than normal, and are turned away because of the refill too soon edits being back in place. Makes sense. We really need to make sure we have utilization management tools in place, but having a year where that was relaxed might be a little bit challenging going back to normalcy. If those people are turned away and they have transportation issues, they might not be able to get back in time to fill their medication on time. So it can lead to real medication adherence issues if the people are just used to that earlier refill pattern. And then likely that's going to make the person upset. And if we're rating access to pharmacy on the CAP survey, they may rate that pharmacy or that plan a little bit lower because now they've experienced this pushback that they weren't receiving in 2020. So yeah, I think there's definitely chances that some of this will swing the other way. All of those relaxations, I think, helped really provide care during the pandemic when it was needed, but we might have the reverse effect when we go back to normal.
Yeah, I think you're exactly right, and I think you made some great points. And I think even with the CAP survey, like you mentioned, rating of drug plan, and even with the other measures where, the patients, the members, they don't know always that it was CMS granting these relaxations. They just know their plan was allowing them to access care in a little bit freer way, right? And when that goes away, I do fear that members will think, well, the plan is making it harder for me again, or something like that, right? And then it will play out in at least some slight declines in caps in future years, but we'll see.
Yeah, and it will be on plans to really make sure they message that clearly. Plans that can message that clearly will likely do better on some of those measures, and I'm fairly certain that's the way CMS looks at it. If the industry moves backwards, there's an opportunity for plans to do better and really get to the head of the pack there.
The one thing I'm thinking about, especially as we're talking about extreme and uncontrollable circumstances, right, and as we're seeing some of those utilization trends that Chris was referring to, if all of a sudden we see utilization trends in 21 over 20 or in 22 over 21, right, that start looking negative, then we're going to be in a situation where those triple weighted adherence measures, which determine so much of a Part D plan star rating, right, or an MAPD plan's Part D component of their star ratings, we're going to start to see declines there. And so could be a real challenge, I think, in future years as we come to terms with more of a normal, I'd say, approach to access to adherence medications. And those Part D improvement measures may struggle in terms of year-over-year rate changes as a result.
Thank you. So one of the questions that I had in, thinking back in March, April, May of last year, considering worst case scenarios, what were the changes throughout 2020 that really were not as pronounced as feared? And David, I'll hand that to you.
Sure. Well, thank you, Lisa. I think that we have a tendency to sort of struggle. We people have a tendency to struggle when trying to think through risk, right? And if we go back 12 months, 14 months, something like that, this was largely unforeseen. A lot of us were looking to the influenza pandemic from 100 years ago for a read on, how might this play out? And so at the time, 12 to 14 months ago, there was this concern, gosh, the sky is falling. Everything is going to struggle as a result, right? In our STARS world, 100% of measures would fail. Sure enough, as we looked at that data just now in terms of utilization for adherence measures, right, we're not seeing that in that very data-driven approach that Chris shared. And I think there was also this concern about deferred care, right? A worry as we're all serving seniors and disabled populations in terms of deferred care, meaning poorer health outcomes. And this upcoming crisis as it relates to health outcomes associated with just not being able to perform care delivery. We did see that in some cases. I don't think it's as bad as we feared, though, say 12 to 14 months ago.
Thanks, David. Rex, what are your thoughts on what was not so bad?
And just one thing to kind of add to that probably is, cancer screenings were definitely a concern when like David mentioned, deferred care, right? So I know there were big concerns that members would not be getting cancer screenings, and at least some of those, like colorectal cancer screening, actually we saw plans, exponentially increase their adoption of in-home test kits, which are non-invasive. They don't require a person, a clinician to be there in the room with you. So there's no risk of transmission of the virus. So, we saw a lot of that take place, increased adoption and members using FOBT kits and fit kits at home, right, where they were able to, and even Cologuard at home, where they were able to get a kit mailed to them, process it, send it back, and never touch anyone or be exposed to anyone, right? So we saw a lot of that take place, and as a result, those scores don't appear to be declining, at least for colorectal cancer screening, right? We, at least the scores I've seen across the industry are climbing because of that increased adoption. So I think those are some places where we thought it would fall more than it actually has.
Thank you. And Chris, what are your thoughts on what was not as bad as anticipated at the onset of the pandemic?
Yeah, I think a lot on the medication area that I spoke about. Clearly, I think originally when the pandemic started, there was a lot of concern. If you think about the hoarding that went on in just the grocery stores and other, I think there was concern about that with medications too. People were generally scared to go to the pharmacy. And so if you look at more micro level data over time, we saw actual decreases leading up to the closures. But once people realized that I still need medications, we quickly saw a rebound. And so those medication adherence rates, which may have dipped a little bit right as the closure started, really came back. And as some of the data I showed is leading to, really stayed above normal for the rest of the year. So those initial fears were quickly alleviated.
So thank you, David, Rex, and Chris, for the informative presentation and rich dialogue. So we're now going to open it up for some live Q&A with our audience.
All right, so now for the fun part. Looks like the most popular question is related to if the presentation recording will be available. And yes, it will be available on the event site through June 11th. And then we have a few more popular questions, so thank you for answering those, folks. The first question is, what was the impact of COVID on performance on the SUPD measure?
So I'd be happy to jump in there first and just mention what we saw is a general steady increase, say about 1 to 3 percentage points on SUPD, which we were pleased with. Unfortunately, for some of those contracts that have struggled more on SUPD, haven't been able to pursue that sort of breakthrough provider engagement approach to SUPD that's necessary. And so was looking forward, I think, to really having that be a plan throughout the year last year, and the ability to engage with those practices, especially practices who may be less inclined to be open to prescribing statins. That's the setback, but it gives us a challenge to work on here now in 21.
Yeah, I'll say very similar. I think some of the data I showed, some of the new starts were down. So things like starting a new statin, it's harder if you can't get to your provider office. So programs where we're trying to engage the offices were closed. They weren't taking a lot of phone calls early on, especially, made it a little bit challenging. I think, again, things really rebounded towards the end of the year. And so I think we're ending on a positive because so much pressure we put on really trying to get those people started on the right therapy. But I think initially there was some concern. We'll see what happens as we go into the rest of this year too.
Yeah, and I would just wrap it up and say we don't have all the data yet, right? We won't have it until a few months from now, but yeah, I would just echo what these guys said. I think it's not as high of a lift as we're seeing in the adherence rates and some of the other measures, but it's not necessarily a decline like we're seeing in some of the measures like diabetic eye exam that require in-home treatment. So yeah, it's definitely I would say a minor increase kind of across the industry.
Thank you. All right, moving on to the next question. Can you describe variation you're aware of related to geographic area or plan size and performance during the pandemic?
Yeah, I can start here. Definitely there were areas that were more heavily hit by the pandemic than others. In the South, we definitely saw some decline, especially early on. Some of that didn't really go up as much as we'd hoped. So we know there are some challenges that continue even till today. I think it's more impacted to smaller contracts as well. Obviously, it's easier to swing some of those contracts on some of these quality measures when you don't have as many people in the denominator. It can go both ways. You can decline quick and you can rebound quick. So I think there's just more volatility.
Yeah, Chris, I'd say the law of large numbers is alive and well in star ratings, right? And so our larger contracts typically see more stability as they have that sort of tendency to the mean. Those smaller contracts, fluctuation either way, to your point, can drive that towards improvement on the smaller contracts, fewer care gaps to close, that sort of thing. One thing I think to be wary of, I feel like it just had a greater effect in 2020, is minimum denominator threshold, right? Started to see for more measures than we've seen in the past, fewer contracts hit that minimum denominator threshold. And so it's important to factor that piece in, because while that may apply measure by measure, right? If you're missing out on a 5-star measure, or if you're missing out on a 1-star measure, right, can have a pretty large swing. And that was an effect, I think, where let's say 18 months ago, I wouldn't have expected that to have such a large effect on 2020.
And we won't see it all for a little bit still, but I would anticipate some changes or some more impact in the urban areas, obviously, right, with the impact of COVID in those areas. And then I think, even aside from size and in geography, I think where we'll see a lot of variances in how member-centric plans are. I think the member-centric plans, the ones that are really member-centric, not just saying it, but actually, and I touched on it, in the presentation, but holding members' hands throughout this, 15-month ordeal, I think we will see those plans have, significantly higher performance across CAHPS measures, satisfaction measures, which I think will also, find their way into compliance measures and adherence measures where, members trust that plan a little bit more and maybe listen to them a little bit more. I think that's a place where we'll definitely see some variance.
Thank you. We have another really popular question. Appreciate those insightful responses. It seems that the 2020 adherence data may support the removal of the clinical edits that restrict access to medications like refill too soon, quantity limits, step edits, et cetera. Would the panel agree with that assumption? And I can repeat it if you need.
So I'll start by saying probably not. I think in many cases they're required. If people needed to get medication and they needed to get it because they didn't have a trip or transportation back to the pharmacy, we needed to make some accommodations for them, especially early on. People were afraid to go to the pharmacy, and so they wanted to minimize those trips. So if you had refills that weren't due, you needed to get them, you didn't want to come back next week. So it's very clear we needed to open up some of those edits. I don't think we want to remove things like prior authorizations and step therapies. They're there for clinical reasons. Most pharmacists have access to override codes. I know Cigna is not turning those off. It's something that is available and at the pharmacist's discretion. So if somebody really needs this in an emergency situation, those are there. Now, we're not seeing them be used. That's a good thing. People are more comfortable getting access to their drugs. But if they need to, that's always there at the pharmacist's discretion. But I don't think it's something that we want to make a very broad policy on opening that up.
Thanks, Chris. Any other thoughts?
I would just say I'm not a clinician, I'm not a pharmacist, and so I see the refill rates obviously have gone up, which is I think the questioners why they're asking the question in the first place. But I think Chris makes some great points. I think these safeguards are there for a reason. I think we can make these safeguards pain points at times, right? And we can do a better job at that, but they are absolutely there for a reason. And I think we can't just look at the refill rates and say, okay, we should relax all edits because of the impact on refill rates.
Well put, nothing to add.
Okay, I have a follow-on question so somebody asked a related question. Does the increase in the inherence rates demonstrated in 2020 data seem to outweigh the potential increased cost with relaxing clinical edits and any data on improved outcomes?
Yeah, I think it's too early. I think it's something we're going to monitor. We know people fill their medications more often. Does that necessarily lead to better outcomes? And is there cost effectiveness in that? I don't think we know yet. We know measuring adherence the way we do is an administrative measure. It's really not looking at did they take the medicine. We don't know if people have just accumulated a lot more medicine. With some of the concerns, people may want to have larger stocks on hand. Doesn't necessarily mean you're going to have better clinical outcomes because you have more pills available. We know it helps. So I'm not saying it's not something that was important, but I don't think we know right now that it's going to have a great impact on true clinical outcomes, but something we need to pay attention to, and we definitely need to monitor.
And with respect to total cost, right, or effect on cost, we know the total cost of care in 2020 per member per month diminished, right? But that's due to a large shock, right, which this presentation and so much discussion is about, right, associated with the pandemic. And so I think teasing out the effect of policy changes given that shock that the pandemic had, hopefully we won't be in a position where we can sort of have a robust historical data set and can kind of separate variables, that sort of thing. But we do know that the total cost of care diminished. As to responsibility for each piece, as it relates to different policy components, that'll be tough to see how that plays out.
Thanks, David. So the next question is related to patient experience. That the patient experience waits seem to be increasing significantly. At the same time, health plans are struggling to reach members and provide the needed access to care. Is that a risk that health plans should be thinking about?
Yeah, absolutely. It's a huge risk, but it's also, a huge potential for a competitive advantage, right? So, member experience, like I said in the presentation, right, is more than half of stars now, or starting for 2023 stars, which is measured this year. I think we will see a lot of plans suffer because of that, because they didn't do a good job of holding members' hands again, right, throughout this 15-month period. But it's not too late. I guess the positive is that the CAP survey, which makes up a third of stars all by itself, doesn't rise to a weight of 4. Those weights don't double until the 2022 survey, which looks back on 2021. So you still have almost the full year to influence those results and to do a better job of reaching out to members and making sure they're okay and providing them access to care and things like that. So I do think it's a huge risk, but I can't overstate the fact that it's a huge potentially a huge opportunity for a competitive advantage too.
Yeah, it calls for tremendous attention, right? Calls for tremendous attention this year, this experience that members have in 2021. When surveyed about it next spring, that will be based on that quadrupling in weight. And so I think it can be Rex, to your point, you captured it well. I think it can be a tremendous opportunity to focus on, and it is a risk, right? If there's a lack of focus on that, then that's a big piece of exposure. CMS is being crystal clear with us on this. This matters, right? And they want this to be a greater component of star ratings, which makes sense. And so focusing on this, removing the risk and delighting in it, right? Really enjoying being in a position to satisfy members, uncover root causes, apply QI improvement cycles, right? There's so much opportunity here, especially if you're coming from behind relative to other plans.
Yeah, not much to add. And you guys covered it well. Not only is it CAPS, right? There are other customer experience and access measures. So thinking about complaints, retention, all of that matters. Not only making sure they rate the plan well on the survey, but the things that they actually can do, voting with their feet, for example, really important right now. So making sure we delight patients, customers, everything. David, I agree. And it's something that I think a lot of health plans really want to put their focus in.
Thank you. So this next question is very interesting. So digital blood pressures assessed during telehealth. Is this the Bluetooth connected blood pressure monitors that upload and feed data, or digital automatic cuffs patients may have? Would they count in both phone and video visits if the patient takes the reading while at the visit?
Can I jump in on this one?
Go ahead.
So this is something that I've really enjoyed doing a lot of work on recently, and it doesn't need to be as sophisticated with Bluetooth enabled devices, that sort of thing. So minimum standard in the revised NCQA specs, what needs to happen is the patient needs to report their blood pressure, and a provider needs to record that in the medical record. And so it can get to the provider in a very sophisticated Bluetooth-enabled way, right? It can also be the cuff that we've used since we were all kids, right? When we go to the doctor's office. And so it can be $20, $30 at the pharmacy, something like that. But the goal here is to ensure that the patient is in a position to share that blood pressure reading either in a telehealth setting, even over the phone with a provider's office, and then that be included in the medical record. And then that's going to be something that counts as evidence for the HEDIS measure. It's a big advancement, and the timing of that could not have been better, right? Associated with the pandemic and being able to enable remote patient monitoring.
Any other comments? Okay.
David covered it well.
You covered it well.
All right, thanks, David. So the next question is also related to CAPS, patient experience. With the incorporation of relaxed point of sale edits and increased delivery options, are there early indicators on the impact across industry on the CAPS getting the needed RX measure?
There is, yeah, I'll jump in on this one. So, we in the last recorded CAP survey in 2019, the national average was, I think, right around 90 on this measure, 90% basically, and we're kind of in the middle of the CAP survey period right now, and we see preliminary reports coming out. There's about a month left almost a month, maybe actually 2 to 3 weeks at least of CAP survey fielding that's still happening. So this rate will change a little bit, but we are seeing this rate at more like 91.6 right now. So it's closer to 92. It's a pretty good increase over the national average from before, which I would imagine is because of those relaxed edits and things like that. Members were able to access their drugs a little easier than they have been in the past. Now, one interesting caveat is there are 3 questions that feed into that measure. Basically, how easy was it to get the prescriptions that your plan or that your doctor ordered? How easy was it to get them at the pharmacy, and how easy was it to get them through mail order? The mail order question is the only one that's actually seeing a decline right now. So I think that points to the relaxed edits, members being able to go get a big supply at the pharmacy maybe, but not necessarily taking advantage of mail order always. Or if they did, they experienced some kind of pain point maybe with mail order. So I think there is an opportunity there, but to answer your question, yes, we are seeing a bit of a lift in that rate so far, at least.
Rex, I hope you're not blaming the U.S. Postal Service.
Not at all.
Yeah, so I think we're seeing the same thing. Generally increasing on this measure, not necessarily just due to the relaxed edits, but think about all the things that pharmacies have done to make sure people have access. A lot of retail pharmacies are doing home deliveries. So I think there's just been a lot of focus on making sure people get access to their drugs.
Yeah, I agree. I think everybody captured this really well. That mail order piece, seeing the exact same thing. And once again, when your CAP survey or any member experience survey gives you a read on a declining measure, gives you a read on an area where your contracts are struggling compared to other contracts, right? That always strikes me as an opportunity. Okay, we can do this. Okay, we can gain some ground, right? What's harder is actually maintaining performance that's above the standard, right? Maintaining performance that's above national average there. And so we've been seeing the same things, Rex, that you mentioned, and no one's blaming the postal service, Chris. I like that. But I think that there's a lot of opportunity to serve members better, as is captured on that measure. And then the great thing about CAPS QI is then you can see that improvement play out over time, right? Due to focused effort. And so lots of opportunity, I think, for all of us plans across the country to improve on that measure.
Well, thank you. We're going to have that be our last question. Really appreciate the insights that you've provided related to policy, data, answering these questions. I'm going to continue to reach out to you guys and have some COVID-related quality touch points so we can keep up on this and supply that information back to our members. Really appreciate your expertise. Thanks again, and thanks for all the questions. And back to Lauren Kirk.
Thank you, Lisa, and thank you to our attendees for joining us this morning. Day 3 of the 2021 PQA Annual Meeting is underway. Next up is a block of focus sessions, followed by collaboration time and office hours with the performance measurement team. You will be able to watch encore presentations of select focused sessions from yesterday. And then I'll see you back here in the afternoon to discuss the real-world implementation of value-based care with Micah and a few others. Thank you for joining us for Day 3 of the 2021 PQA Annual Meeting.